Eastern time. So this is great. Alrighty, so Bill, you want to take it away and get the morning going, or what do you want to do?
Sounds good. Are you running on the beach, Dr. Q? I can't tell where you're at.
I am right here. Look at the entrance of the hospital right now. I'm coming around the corner with you guys, and just want to make sure that people get a sense. The conference room, which is the big one, is right next door, and we're trying to keep social distance. And here we are. Good morning.
Morning.
There's the room right here. Keep your social distance with everybody. All right, let's take it away.
All right, well, thanks everybody for being here this morning. Welcome to our second edition of Social Distance Jeopardy. I think Dr. Janus is going to be our sole participant today since he's our guest of honor. Yep. So we have 5 categories. We're going to have everyone in the room participate. So if you have a question, just kind of shout it out. We'll just make this fun. We're not going to make it individualized as we usually do. But categories today are 60% of the time, works every time, I see you, baby drama, our random category, potent potables, and shake it up baby. So we're just going to start from the top. So what percentage of pediatric ependymomas occur in the posterior fossa? Anybody know? 60%. That's right, 60%. Right. What percentage does a child have of acquiring NF1 with one parent affected by the disease? 50, good. Autosomal dominant. Nice job.
21, 50%.
There you go. According to Ishmael, what is the likelihood of rupture over 5 years for a cavernous carotid aneurysm measuring 1 centimeter in diameter?
0.25.
0. Good job. 1 centimeter, not greater than a centimeter.
And make sure that you speak loud because these microphones are picking up the sound here.
What is the absolute risk reduction of stroke in endarterectomy patients with symptomatic 70% carotid stenosis according to the NASA trial compared to medical management over 2 years? 17. Good. So 26% stroke rate minus the 9% stroke rate. So 26% stroke rate with endarterectomy minus 9% with medical management gives you 17%. They'll ask this every single year. All right, percentage of children with hydrocephalus and myelomeningocele that will require shunting. 90%. Good job. All right, no more percentages. This cranial nerve of eye movement is not contained within the annulus of the head. Good. Trochlear nerve. Short ciliary nerves belongs to this part of the autonomic system. Parasympathetic. Very good. Horner syndrome that spares the face is likely caused by a lesion in this location. Good. This is an internal carotid artery, so postganglionic or third order. So remember the sympathetic fibers to the face actually come across the external carotid artery. This type of cell membrane receptor facilitates phototransduction. Cell membrane receptor. Biology 101. Right. It's the OG protein receptor. All right, remember the G protein. If you when in doubt, just pick this one. All right, a patient with a thunderclap headache, sudden visual loss, and multiple cranial dysfunction has this finding on a non-contrast CT scan. What's the next appropriate step?
Surgery.
Anyone?
To go to an endoscopy.
You do a biopsy of this?
Diagnostic surgery.
Surgery. It means it seems to be an apoplexy.
Right.
Right.
So your differential is what? Pituitary apoplexy.
Skill base aneurysm.
Yeah, good. So pituitary apoplexy or aneurysm, right? So you always want to rule out aneurysm.
Apoplexy.
Yeah, perfect.
Yeah.
Unilateral abscess of a moral or absence of a moral reflex in a newborn with a difficult birth is suggestive of this injury. Right? Good. So what's a moral reflex? Who's got kids?
Grasping for life.
Yeah. So when you drop them, their arms extend and come out like this. So if you only have it on one side, usually that's suggestive of brachial plexus injury. So what's the most common brachial plexus injury in children, or newborns, I should say? Upper trunk. Good. Yeah. Cerebral palsy. Good job. Ulnar grasp is typically seen at this age. When your kids start grabbing for things on their food tray. Yeah, good. 6
4
months.
months.
Yeah, about 6 months. Most common cause of congenital hydrocephalus. Good. Knock it up.
Congenital.
Nice. Good job. I like whoever's participating on Zoom. Thank you. You're the first participant to ever join us. This is awesome. Diagnosis and grade. Good. Grade 4. Nice. All right. This tumor most likely arises from what part of the fourth ventricle? Good. So what is it?
Fourth.
Nice. Good. Endoboma, right? So which tumors arise from the roof? Medulloblastomas. Good. All right. Random category. 3-year-old with neck pain falling off trampoline is absence of fusion of the posterior arch of C1. What age is this typically completed?
7 years?
Was that?
7?
Yep, exactly. 7 years.
Yeah.
So between 5 and 8 years old. So the largest study that was done showed that about 16 out of 108 kids had absence when they were 7 years old. I think it was 2 out of 108 kids or 110 kids by the time they were 8. So by the time that you're 8, you should see complete fusion of this. All right, this condition can be seen in patients with this chromosomal disorder. Yeah, again, when in doubt, it's probably that. This is Bassar invagination, platybasia, and you can see the retroflex dens and then causing a large series here.
Down syndrome.
What would be your first treatment choice for this? What's the first thing you would do for this patient? Or what imaging study would you want to look at before you would try to treat them? If you want to look at the occipital-cervical ligamentous complex to make sure there's no atlantoaxial dislocation, right, or atlanto-occipital dislocation. And then you'd want to put them in traction, if that was the case. Okay. You always try to reduce this with traction first before you're taking the operator. 25-year-old female with seizures and a non-enhancing lesion on MRI. All right, who likes fried eggs? That's right. Okay.
Oligodendroglioma.
Nice. Hyperdense extraaxial supratentorial lesion on non-contrast CT is most likely a angioma. Muscle biopsy in a patient with chronic TA weakness. Anterior tib.
Polymyositis.
So what would you see with polymyositis?
Yeah, like leukocytic.
You would see small blue cells actually infiltrating the muscles themselves, right? Do you see that? No, they're kind of just around them, right? Okay, so same thing.
Or inclusion bodies.
Okay, so inclusion bodies, you would see inclusion bodies, which you don't see here. What do you notice about these atrophied fibers? Okay, so you see these big sacs here, these are all normal. And then there's just a small group of them that are atrophied. So what does that tell you? Denervation. Exactly, okay, so this is a motor unit. So this motor unit is denervated. So this is denervation atrophy. So there's only really 5 things that they're going to ask you. You guys pretty much hit them all except for the right one. So dermatomyositis, any sort of inflammatory myositis, inclusion body myositis, denervation atrophy, and then some of the glycogen storage disorders. So it's really important that you guys just recognize these patterns because they will ask you for your tests every year. Most common hereditary ataxia.
Right.
There you go.
Friedrich.
All right. What's the diagnosis? What's this called?
Lewy body.
Lewy body. Nice. The pink eye. Anti-tau stain.
Alzheimer's.
I hear a lot of different answers. What is it?
Alzheimer's.
There you go. Nice. So what are these things called?
Neurofibrillary tangles.
Neurofibrillary tangles.
Tanglers.
Remember, anti-tau. Okay.
Anti-tau.
Is a patient with headaches and seizure 10 days after DVS implantation. What's your differential?
Infection.
Okay, good. So this is a contrast or
Infection?
non-contrast?
Infection?
This is a non-contrasted scan. Okay, so just look at the sinus. This is a contrasted, so you can see there's some early contrast enhancement here.
CNA infection.
Yep, nice job. All right, let's go to Final Jeopardy.
Hey,
So if everyone-
Bill, before you go to Final Jeopardy, we had a participant that was hitting a lot of the right answers on the phone. Can we identify who that person is?
Andrea Ortiz.
Andrea,
That's
thank you
me.
very much.
Good
Andrea.
morning.
Wonderful. Good morning. Where
Good
are you
morning.
joining us from?
Ecuador.
Wonderful, Andrea. Welcome. I know we have people from Colombia, Ecuador, and I think we have some people from Peru as well, in Mexico.
Yeah, thank you.
Wonderful. All righty, Final Jeopardy.
Nice job. So if you guys want to play along today, what you can do is you can text the number 22333 for our domestic participants. For our international participants, if you go to pollev.com/WilliamCliff302, then you can join our session too. And then you guys can play along with the question.
And let's make sure that for the future events like this, Bill, we send it to all our international participants. So that way they know. All right.
All
right. Give you guys a couple seconds to join here.
For us, it's 22333 on the phone.
Right. All right, so this is an X-ray of a newborn that has failure to thrive and has never had a bowel movement. This is a colonic biopsy.
Could you please repeat the code for the international students?
If you go to
Thank you.
So you can write it in the chat, you can copy so they can just click.
So POLLEV.com/WilliamCliff302. Oh, and then I guess Gaetano's going to put it right there in the comments so people can see it.
Yeah, thank you.
And we're going to have 5 choices, all right? A, B, C, D, and E. And anybody anonymously can put whatever they think is the answer. And what Bill is doing is collecting data. And now we'll be able to collect data not only nationally, but also internationally.
The link is now in the chat, so if you want, you can just click from there.
Excellent. Thank you, Gaetano.
All right, so we have a newborn with a toxic megacolon, and then this colonic biopsy. All right, and the question is, which structure is also likely to be affected? I'll give everyone 30 seconds to look at that.
So those are the choices: dorsal, central canal, white matter, gray matter, ventral root, and dorsal root. And we're going to have 30 seconds to answer, and Bill is going to put the choices, and we enter them, and then he's going to begin to collect data. We're missing the music, Bill. And the only problem that I see with this, Bill, is that people are being influenced by the answers that are being put on the board because they can see them.
Right.
So what I recommend in the future is that we stop sharing the screen for a few seconds, and then we share it back again once we get the answers.
Right. What do you guys think? Anyone?
There's already the answer.
All right, why is that?
Because of the migration of from the
Yeah,
neural
looks like
crest,
fish from
because it's a toxic megacolon, so the abnormality, the migration of the cells of the neural plexus.
Good. So if you look at the colonic biopsy here, then you notice that there's absence of Auerbach's plexus right here. So the submucosal ganglion, right? And so the question really is a third order question. You'll get a few of these on your test, and those are the ones that really separate the really high scores from the poor scores. So what they're asking you is, which one of these choices is also a neural crest derivative? And the answer is C, dorsal root ganglion. So nice job, guys. That was a really hard one, but everyone did a great job.
And that was Ricardo actually who answered that. But Ricardo, why cannot be the central canal if we have a lot of, subventricular zone is a remnant, and we have a lot of migration from that region peripherally? Why cannot be the central canal? Ricardo was the one who answered the question. Go ahead and speak loud, Ricardo.
Yes, sir. So the central canal actually is formed, but if I'm not mistaken, by this second neurulation in the process. So it's not about migration of the neural crest. So this is more of a problem with the neural crest migration of the cells from the neural crest. So the dorsal root ganglion from the options is the only one that comes from that embryogenic component, and that's why it's most likely to be the one that is affected, just because of the pathogenesis of the Hirschsprungs.
And the other reason also is because, as far as we know, the only migration that exists radially really comes from the subventricular zone, from the lateral ventricles in the developing mammalian brain. So that is really way high order of thinking for this, but it's a very good question, and that's how you're going to get it asked in your American boards.
Yes, sir. Thank you.
All right.
Beautiful job. Let me come up
Sure,
and
guys.
as you can see, I'm sitting next door here in the Kinney auditorium where we normally have our lecture series, and I'm gonna show you right now. I'm gonna share my video. Normally this is where we are. I don't know if you can see where I am right now. And you can actually see this is the lecture hall where we normally have our updates, and it's empty right now because of social distances. But every Monday at 6:45 in the morning, we start with a update with a usually American Board Neurological Surgeons type of testing. And then we continue at 7 a.m. with updates, which is I am about to do. And then we end up with a speaker, and we end up promptly at 8 in the morning, because at 8:30, the operating rooms are ready. Patients are walking in, and upstairs our nurses and our anesthesiologists and our neuromonitoring team is doing. But this is the beautiful hallway. You can see actually the pictures of a lot of history from the Mayo brothers, and you can see the podium with the Mayo Clinic, the big screen right there. And that right behind me is the two Mayo brothers and their father. So, and then I'm gonna walk right here next door, and we are, for right now, in this room right here that you can see 1107, where you are about to see some of the people doing this. So I'm gonna start sharing this. All right. I'm gonna
mute that. And I muted it. Good morning.
Morning.
Well, thank you.
Yeah.
Yeah, thank you, Dr. Janus, for being here with us. Let's see if we can play this video for our participants. We have people from Ecuador, Mexico, Peru, Colombia. I think they have Dr. Hakim and his team actually who joined us from Colombia. Everybody knows Dr. Hakim, who is not only comes from an extraordinary pedigree. You know, Fernando, can you say a few words? Dr. Hakim, can you say a few words just to welcome everybody?
Thank you for the invitation. All our group of staff and all the residents are taking advantage of this nice opportunity. And one of the good things about this COVID is that we're being able to get together with people around the world that we never did. So thanks a lot, and I hope we can keep in touch.
Wonderful, wonderful, Dr. Hakim. Well, we thank you. We know the extraordinary work that you do with your team, and you guys have been leaders in a lot of innovation. I know that recently you guys were here with Tito, who I think is joining us also, and you guys visited one of our affiliates, the University of Arizona, for new ways of treating potentially hydrocephalus through devices that are run electronically. So thank you very much for joining us, and thanks all the rest of our colleagues from around the world. This is our place. You saw some of the pictures as we're doing. We're sharing our screen right there. That's where many of us live, right in the area. This is the beach. This is a beach town. We're very relaxed. As you can see right here, a beautiful campus. That's actually downtown Jacksonville, which is about 20 minutes away from the beaches. That's what the medical campus is, right in those beaches right there. We are a couple of miles away from the beach. Actually, we are the last exit before we exit into the beach on the actual highway. So a lot of us live along. Just last night, I was going on a run right around the beach, and this is the St. John's River. A lot of dolphins. I remember when I first came to do an interview from Baltimore. Here's a beautiful waterfront, beautiful town, and we welcome everybody. Anybody from around the world is welcome to come and visit us. And we are delighted to have all of you guys here and all the people joining us around the world. I'm going to come back to Dr. Janus, who is going to, I'm going to tell you a little bit about who he is. You can see the exciting talk that he's going to be giving us, surgical ergonomics, past, present, and future. We're excited, Jeff. We're really thinking, looking forward. We already went through President Jeffery. I'm going to give you guys a few updates for a few minutes. We will send all this PDF for you. The Monday and the Friday lectures are open to the world. Why? Because we don't have any patient-related data that we have to be concerned about. That is the Monday, that is today, that is the link. This is the Friday. We also have about 100 participants through virtually that join us, and then many of us who are here. And eventually I did challenge, Dr. Grewal and Dr. Clifton, that when we go next door, which is going to be in the next month or so, we are going to be able to still be socially responsible and keeping distancing, but also equip that big room with all the Zoom capabilities so the rest of the world can continue to join us. A lot more people that want to join us. We have 9 offices in Latin America, and they all eager to join a lot of our physicians who have not only our alumni, but they have also given us a lot of support throughout the years in building bridges. So these are the ones that are not open, because these are working conferences. They're open internally to our doctors and, of course, to our healthcare providers. Now, we could open some of these to our doctors. For instance, our doctors from Mexico, or doctors from other parts of the world, if they want to present one specific case, if they let us know ahead of time, we'll open it for that specific case and then close it again, because that's the federal regulations of the US government. These are the other 3. So we have a total of about 8 conferences. They're all CME accredited, just like this morning. The code for the CME, we're gonna send it, also attach it to the discussion, to the chat, so people can get CME credit, and Gaetano is doing that right now. But these are all CME accredited. Around the globe, some information. We are still at the forefront. Everybody knows, just at the forefront of the national response to COVID-19. Mayo has always been considered the most trusted healthcare organization in the world, and there's a reason why people around the world come to us for advice and how to deal with us, including in Neurosurgery. We're writing an article as to how we deal with the cases, because our caseload didn't really slow down a lot. We're even with the lowest points in Neurosurgery, we stayed at about 60%, and we are all the way back this last week to about 98% of where we were. So we are very, very fast, because a lot of our disease is not elective in nature. A lot of them is urgent to semi-urgent. So this is the vice president. This is in the Mayo Clinic this week. So tremendous amount of attention, obviously, into what we are doing, how we're keeping our patients safe, our healthcare providers safe, their families, and what kind of measures we're taking at all the sites. The 3 main sites, which is Rochester, Arizona, and here in Florida, but there are many of our hospitals in the Midwest that are also part of the Mayo Clinic, and many hospitals around the world that are part of the Mayo Clinic Care Network. This is the Navigator. This is a clinical resource with consensus-based recommendation. And of course, we have a tremendous opportunity for people to learn around the world. I wanted to now move a little bit of a congratulations. This is a tremendous accomplishment by Dr. Clifton, who, of course, with the mentorship of all our spine consultants. I see Dr. Dean right here. Dr. Nantmeyer is probably joining us virtually. Dr. Pickelman, who was here, who's now moved to the Midwest as well. And of course, Selby, Kingsley, and many of our mentors in spine who have given Dr. Clifton mentorship, and he's going to be working at the Linky, with Larry Linky, who is a professor of orthopedic surgery and a chief of division in Colombia. Arguably the best complex spine surgical training in the world for complex spondylosis. So there's going to be a lot of complex spine. And of course, we know some of the accomplishments from Bill, and I'm going to actually feature at least one paper that he and Aaron got accepted last week with Fidel. So these are some of the papers. Last week, I saw Dr. Young. Irvin, I think, is online. Irvin, you want to say a few words about this paper?
Good morning. Thank you so much for the invitation. And well, this is a joint collaboration with multiple people from the Department of the Neurosciences, Dr. Tak from Neurosurgery, and obviously a whole array of people from the Department of Neurology, including Dr. Barrett, Dr. Broad, Dr. Mesquia, and Huang and Lin, and of course the chair of my division, Dr. Hakem, and the neurointerventional radiology as well with Dr. Miller. So we have the opportunity here at Mayo to participate in what we call a VQI, or the Vascular Quality Initiative. It is a national database of more than 683 hospitals who participate, and we perform over 700,000 procedures. So if you, as a participant, we get access to the database, and we can basically query and propose our questions and see what we can answer with this large data registry. One of the things that I'm interested in is in the sex disparities in the delivery of healthcare and the outcomes. So looking into the carotid stenting in the asymptomatic population, we found that women tend to do a little bit poorly in the immediately peri-op procedure time with a high rate of TIA and strokes. However, on long term, the men have a higher risk for earlier mortality. So I'm very glad to have done this paper in collaboration with my colleagues and looking forward to the actual publication.
Wonderful.
Thank you for the invitation.
Well, congratulations. Thank you very much, Dr. Young. I just want to make sure that people understand the tremendous collaborative efforts that we have between our groups. This is another paper that was published by Dr. Chaichana and his group. Is tremendously leading this effort in endoscopic minimally invasive. This is a particularly an odontoidectomy for the treatment of vascular revagination. This is the paper that I mentioned that Bill also published with our team, obviously, with both Fidel and Aaron. So congratulations, Aaron, for another tremendous paper. Tell us, Bill, what BRAIN stands for, because I want people to you started the laboratory basically with Aaron, and I think that this is going to be going into the history of, and some of us have been blessed, I personally, to be able to participate and to support through our grants, the lead investigator, the Mayo professorship, and most recently to the U-Line, which is a tremendously welcoming family. But tell us what BRAIN stands for.
It's the Lab of Biotechnology, Research, and Innovation Neuroscience.
Biotechnology, research, and innovation, and neuroscience. So congratulations, and congratulations. A lot of papers coming up throughout the year, and soon grants as well from the federal government, ideally, either the NIH, DOD, or NSF. All right, the Department of Defense is DOD, National Science Foundation is the NSF, and of course the National Institute of Health. These are grants that are long, they have a long life of a minimum of 3 to 5 years. So congratulations. Ongoing and past events. Kingsley, thank you very much. I think he's joined us through virtually as well. This is representing us last week. And the management, you can actually see, this is precisely the type of work that Bill is going to be doing in New York. Extraordinarily complex amount of surgery. These are very long, complex cases that require an extraordinary amount of multidisciplinary work. And Kingsley, I think, is going to go in the history, at least our Mayo institution, of doing the very first series of awake spine surgeries. And I think Olu's done a few of them with him already by now. So we're very, very excited about this. He doesn't do these ones awake. These are much more complex to be done awake. So as a matter of fact, they're extraordinarily long, and you can imagine the amount of work that it takes. More data for ABNS. We're going to see some publications, and people around the world are joining us. These are our upcoming events. Jorge Navarro from Mexico. Jorge, are you on the line? I thought I saw him. He was going to join us, but he's going to be our speaker next week. He is one of our fellows that spent a year with us, and Dr. Dean actually went to his wedding. And
yes, Professor. Good morning.
Jalisco. Good morning, Jorge. Are you on the line?
Yes, here I am. Thank you. Thank you so much for the invitation. I'm already waiting for next Monday. Okay. Thank you so much for the opportunity.
Give people a sense of what you're going to be talking about next week.
Well, we are going to talk about awake craniotomy. So the way we do it here in Mexico, I learned a lot of the procedure doing awake craniotomies with you there in the Mayo clinic. And now we're doing that here in Mexico. So we're going to share some of our experiences here in Mexico.
Wonderful. Well, thank you, Jorge. We're looking forward to your talk next week. And you can see the lineup of the speakers coming up. These are courses, our live courses for the end of 2020 are going to be moved. The live itself are going to be canceled. We are strategizing as to how we're going to do virtually many of our courses. For sure, one course on skull base with Ravi. I have a meeting coming up with him. And for sure, at least one more course on the spine. And I'm meeting with Kingsley and Bill as well, and Selby and Gordon and a lot of the directors of our courses, because it's important for us to continue to be connected, even if physically we cannot do those things because of social distance. We'll talk more about it. So now I end up right here, Jeff, Dr. Janus. So I tell you, Dr. Janus is a tremendous superstar. I'll tell you a little bit about his pedigree, his training, his accomplishments. We'll hear more about the talk that he'll give, and then, in the what? Oh, live from the lab. Yeah. Oh, we have live from the lab. Let's see how do we go? Sorry, we get three more minutes. We got someone from the lab who's going to show us some stuff. Okay, let's see.
Hey, Lina, are you ready?
Good morning. Hi.
All right, let's see if we can put the big screens.
Share screen.
There you go.
Yeah.
All right.
No need to share, just. So
no need to share, just your screen. So this, let me tell you what this live from the lab means. So last week, 2 weeks ago, Bill Clifton and Aaron, they took us to the lab and they showed us what they're doing with the brain laboratory and the stuff. And we figured we spend a few minutes so people begin to understand what we're doing in our laboratory. So already it started at 5 in the morning. Paola and Lina start to work, and they're gonna take us a couple of things of what they're doing and how they are not only isolating the stem cells in the laboratory, but helping us understand migration of cancer and also tools that we can use all the way from stem cells to nanoparticles in our laboratory. These are all grants. We have over $15 million of NIH funding in our laboratory altogether between my lab, Google's lab, and some of the other labs. So go ahead, Paola.
Hi, good morning, everybody. Thank you for joining us today. Welcome to our laboratory. Can you hear me well?
Perfect.
Okay, great. I'm Paola Mir, one of Dr. Quiñones' research fellows, and today I'm going to take you to one of the most exciting parts of our laboratory, that is the culture room. This is a place where tumors that are resected in the operating room by our neurosurgeons are delivered for immediate tissue processing and cell line establishment. So we get different types of tissues such as GBM, chordomas, metastatic brain tumors, mesenchymal stem cells, CSF, and blood for different experiments. And right now I'm going to show you a little bit more about it. So let's go. Let's see. So this is where it all starts. As you can see, we have to wear all our PPE in order to keep ourselves and our cells safe. So this is our room.
And Paola, this is normally what you do. You don't even, I mean, this is whether it was coronavirus or not, that's what you would do anyways going into that room.
Every day. Yes, sir, every day. So here we are at the set with the hoods. And here's Lina. Hi, Lina.
Hi, everybody.
Good morning, Lina.
Hi, sir. Hi, my name is Lina Marenko. I'm a research fellow in Dr. Chichana's metastasis lab. And as Paula was saying, once we get the tumor tissue, we bring it to this room and we work under these hoods. As you can see, we have a total of 6 hoods. They are sterile and they help us keep our cells free from any contamination. The first thing we do once we get the cells, we place them under the hood and we start dissecting any vessels, remove any debris, and we centrifuge the cells. That way we only obtain the neoplastic cells and we plate them. We allow them to grow before we can actually start working on them. The cells are then placed in these incubators right here, which are temperature controlled and have a specialized environment that help these cells live and proliferate. So right now, I am working with lung cancer cells, and I am changing their media. This is very important because the media actually contains a lot of nutrients and factors that allow these cells to grow. And once we're finished, we place them in the incubator. You can do a lot of experiments with the cells, depending on what the goals of your project is. And once you're done, you usually visualize them under the light microscope.
Let's go
Lina,
see some cells.
Elena,
Yes,
you said lung cancer cells, and I think just to put it in perspective, these are lung cancer cells that have gone either to the brain or to the spine, which we now understand that have very specific receptors that allow them to survive in that microenvironment that is not their native microenvironment.
Yes, sir, that is correct. We're currently studying that in the metastasis lab.
So let's go see some cells. Hi, Mew.
Hi, I'm
You, good morning.
Good morning, how are you? I am the research technologist in Dr. Q's lab, and right now, as Dana said, we usually look at our cells that we're growing underneath the light microscope. And what I have here are glioblastoma cells that are growing. We are growing in neurospheres. And with these cells, we grow them as neurosphere for 3 passages before we plate them and laminate them and expand them on laminate coated plates. Depending on the objective of the experiments, we can either grow them as spheres and run functional assays to better understand the GBM cells, or we can grow them as acute cells and test them with therapeutic strategies and kind of study the efficiency of how they are attacking the cells. In this workroom, we have all of the necessities for cell culturing. Here, we keep all of our reagents and cell culture media to grow and maintain the cells. We have a centrifuge, a light microscope, our bi-cell XL cell counter, as well as our bead sterilizer to sterilize our instruments and tools, our bead bath to warm out our media and reagents, as well as essential equipment like the hood and the incubators.
So thank you everybody for coming to the lab with us today. We appreciate your attendance today to the meeting, and we are as a team very grateful with other patients for letting us study their tumors and advance the science every day.
In the next couple of weeks, we'll be showing other parts of our laboratory, and hopefully you can meet other lab members.
So thank you, and so back to you, Dr. Q.
Wonderful, thank you guys. That was amazing. You got to see about 1/10. So we have about 30 laboratory members between our labs, and you got to see about 1/8.
My ears like yours.
And it is amazing to hear them, and so excited. They're still, it's exciting. And I think that it was 2 weeks ago that Bill challenged us, and now you can see they learned from what you did 2 weeks ago, and now their challenge is to make it better and to get us excited. So we'll get to see more over the next few weeks and throughout the year. This is something new. It's for the world to see what we're doing. So I go back to Dr. Janus because I think that it is what you're going to hear is the qualifications, and then I'll end up with a little bit on the personal side. So this is his training. He got his bachelor's medical school at the University of Florida in Gainesville, which is not far from us, a couple of hours. Yeah. Originally from Florida as well, family in Florida as well. It's a tremendous. And then they recruited him to Rochester and Mayo to be a resident. And then in a few years, he became a vice chair and a chair of research, in really a meteoric rise in his career. A lot of awards, a lot of developmental grants, teaching awards, research awards, you name it. The department under his guidance and research really catapulted to extraordinary levels. And of course, many publications. This is the what our team got together in regards to his age index, which is something that we track for all our faculty. We are tracking it for our residents, actually, as soon as they are interns. And it is very important. That tells you how much of an impact you have in the literature. And the talk that he's going to give us over the next 30 minutes or so has to do with the surgical ergonomics, past, present, and future. And a personal level, actually immediately after this, we are doing a stage 2 of an extraordinarily gigantic clivus and lower skull base chordoma that we did a couple of months ago, the first stage, and we're going to do second stage today, and then the third stage is going to require neurosurgical fusion by Dr. Kingsley tomorrow. And that tumor, we sent it to the laboratory that day. I remember Jeff and I, that tumor was part of a database that Dr. Akinduro actually used recently to write an NIH grant. And it was just such an amazing amount of pleasure to talk with Jeff, not only about research and education, but the way that he cared for patients, the way he is available for patients is really, truly inspiring. He's always available anytime, 24/7, anytime I want to call him about a patient, any issues that we have with patients, even if they're not his patients, if they're someone else, he's always ready to step in and help. So we thank you, Jeff, for being here with us. We look forward to your talk. We're going to put it right here, and then we'll have a good time over the next 30 minutes or so.
So the CME code for today is ZESSEW. It's also in the chat if you're interested. Okay, everybody, thank you so much for having me, and thank you to Dr. Q and the Department of Neurosurgery for having me for this talk. Although I do a lot of skull-based work, and I've done so in the past, and continue to do cases here with Dr. Q and with others, the vast majority of what I do is head and neck oncology and reconstruction. And so I was trying to find something that I try and implement in my practice every day that would be applicable to most of the people in this room and maybe change the pace a little bit. And so I think I thought we would maybe do a talk on surgical ergonomics, which is something that I've tried to implement a lot in my practice over the course of the last couple of years in particular. As Dr. Q mentioned, I graduated from the University of Florida. Just to give you guys some background on me, everyone keeps on asking me how I like Florida and is it too hot down here for you? And I grew up here, so this is me with I had a lot more hair and a lot more weight at that point in time. I graduated from the University of Florida, then went from there to Rochester, Minnesota, where I did residency fellowship and eventually stayed on staff. I got to see some interesting things there, like the inside of doors freezing when it's negative 40 out and stuff like that. And I stayed on staff there after I graduated my head and neck oncology and reconstructive surgery fellowship. When I was at University of Florida, I met my wife, Lindsay Williams. She's a cerebrovascular neurologist. And so if you like her, that's great. Come let me know. If you don't like her, then I don't want to hear it. But she's fantastic. Obviously, married somebody who's way smarter than I am, so I'm happy about that. So over the course of the last year, this is around January, February of last year. I've gone from that to now coming back home to being with family. My kids playing on the beach, and this is basically the kind of lifestyle that I grew up with, and so it's nice to be able to bring my family back here to do this. Perhaps the thing I'm most proud of is the fact that I've come back to Florida to be part of this department, the Department of ENT, where I get the opportunity to take a leadership role with this team of individuals who are incredibly hardworking, incredibly good at their job, and incredibly smart and talented in their respective fields. And you can see the other 8 individuals that I work with up there on the screen right now. I think almost every person on the screen is involved with some sphere with neurosurgery. Angela Donaldson, Noma Alomo doing anterior skull base and rhinology. Larry Lundy doing lateral skull base in the field of neurotology. Philip Pergustis, John Kassler, and myself. All doing some element of head and neck surgery as it applies to neurosurgery. So lots of people in our department involved with the neurosurgical department, and indeed I believe that a good relationship between the ENT department and the neurosurgery department is indicative of a good institution. And so I'm very pleased with the relationship that we have with neurosurgery. I'm very proud of the people that I work with. I have nothing to disclose in this talk, other than the fact that a fellow, a head and neck reconstructive surgery fellow, and I did a lot of work on ergonomics. She has given a similar lecture Her name is Lenny Reddick. She's now at Brigham and Women's head and neck oncologist and reconstructive surgeon there. So if anybody on the line is in that area and you want to know a good head and neck surgeon in your region, she is phenomenal and is a really fantastic human being to boot. So things that I was noticing, I'm a woodworker as a hobby. I'm not very good. I'm still learning, but things that I was noticing was that my hobby, for some reason, was making me less sore than my job. And if you can imagine taking 400 pounds of rustic cherry, which is what you see here on the left side of the screen, and taking some plans, taking some sort of questionable helpers, okay, so not very good help, and then turning that 400 pounds of rustic cherry into a dining room table for your home. I was noticing that for some reason, the way that I laid out my shop, because I had taken some ideas from other individuals, the right height for my bench, how to make my miter table, what height I should put my caster carts at, what height I should put my table saw at, all these things were making me allowing me to take very heavy pieces of wood through very dangerous equipment and doing it in a way where I wasn't becoming very sore at the end of the day. And then I would go do a parotid surgery Monday after tinkering on the weekends, and on Monday night, I'm really sore when I get done. So I started to look into the background of surgical ergonomics. And I'm like, well, why am I able to handle 400 pounds of wood and turn it into a table and be just fine, but my job for some reason is what's actually causing me to have cervical spinal pain at the end of the day. We'll talk a little bit about backgrounds, prevalence, and exacerbating factors that applies to ergonomics, but basically ergonomics derived from the word ergon, which means labor, nomics, which means arrangement of, and there's actually a definition by the International Ergonomics Association Council on what exactly this is, which is, long and short of it is it's the relationship of maximizing people to a system to optimize performance and well-being. That's the bottom line of what the study of ergonomics, or ergonomics in general, is. Ergonomics did not exist as a field prior to about the turn of the 20th century. Then all of a sudden, Frank and Lillian Gilbreth, who contributed equally to the study of work and systems, and actually she received, for the time, I think, an amazing amount of credit as she was on, her name was on every paper that Frank and the Gilbreths published, and was also on the movie that they made on ergonomics. And what they did was what we call a motion study, or what they call the motion study. And the purpose of that motion study was to study the motion and study motions and reduce them as rapidly as possible to standard sets of least number, least fatigue, and most effective motions. Okay, and they started out studying bricklayers. So if you look on the right side of the screen, this was a typical bricklaying site in Boston before Gilbreth's methods were applied. I mean, you can see the bricklayers would have a little line that they would work on right here of bricks, and they would all get their pile of bricks that they would bend down to grab, and someone over here would apply a layer of cement between the bricks, and then all these guys would randomly stack bricks. Okay, and when Frank and Lillian Gilbreth studied this, they said roughly every bricklayer was using 18 motions and laying about 120 bricks per hour. They said, well, why don't we come up with a standardized way of stacking the bricks so that you don't have to reach very far for them? And why don't we also have this scaffold where none of you guys are bending over, but rather standing up with, posture perfect, and just reaching over to these stacks and then putting the bricks in place. And then using those standardized protocols, they were able to reduce bricklaying motions from 18 to 4.5, and the bricklayers were able to lay about 3 times as many bricks using about 1/3 of the motions. And so that was one example of the different types of things that they studied during the motion study. They also took a look at surgical suites. And directly from their paper, after a study of surgical methods used at the time, Gilbreth reported having found a waist so enormous that it was unequaled in his experience. And also, he was the first to suggest that the surgeons get a caddy, much like a golfer. And so you can thank Gilbert for your CST, because it was originally one of his ideas to have somebody hand a surgeon instruments. Prior to this time, surgeons were grabbing their own instruments off the tray. It was kind of interesting when you look back on how he did this. All of his studies have timers in a corner that as part of the filming that he does. They're also, all the rooms are all gridded off. If you look at the surgeons, this one's a number 3. This person's a letter A. I don't know why they use different, like, it's both alpha and numeric, I guess, but he when he studied surgery, he found an enormous waste of motion. Really, off of Gilbert's working forward, it wasn't really until World War II that the government started to play a larger role in ergonomics, and things became a little bit more standardized as far as, airplanes, like things being in reach, pilots being in a comfortable position, pilots being able to be awake for a long time, that sort of thing. So a lot of, around the time of World War II, some significant advancements were made in the field. Again, kind of coming back to surgery, however, surgeons' work environment is and working conditions are often harsher than those of an industrial worker. And accepted principles and regulations of ergonomics as they apply to industry are oftentimes ignored or absent in the medical and surgical domain. Indeed, when you look at OSHA and their guidelines, there are innumerable things that are listed as high-risk occupations and standardized guidelines for many of the things that industrial workers and plant workers do on a day-to-day basis. But at this point in time, there's only one guideline that's specific to healthcare, and that's patient lifting. That's it. Everything else isn't really standardized from an OSHA standpoint. And so, as I think more and more people are starting to realize that there's a lot of work to be done in this field. We've now seen sort of a litany of papers come out over the course of the last 1 to 2 decades that have to do with surgical ergonomics. And I think we're starting to see a change in the field, and a lot of these things are being implemented to give surgeons the opportunity to operate long term. When we look at work-related musculoskeletal disorders as it applies to surgeons, about 60 to 90% of surgeons report musculoskeletal pain while operating. Most of it winds up being neck or shoulder pain. And honestly, these aren't just like people feeling sore. And I think when you're saying, oh, you just kind of feel a little bit sore, someone would be like, well, take some ibuprofen, you'll get over it, just tough it out, kind of a thing. But these are sort of real problems. People, not an insignificant portion of surgeons wind up with cervical spinal disease, rotator cuff pathology, L-spine disease, basically types of work-related injuries that would require intervention or even surgery happen in about 10 to 20% of surgeons long term. This has been demonstrated in this systematic review and meta-analysis of over 5,000 patients. Again, we see this again in a systematic review, a different systematic review and meta-analysis of another 5,000 patients. But basically, over 50% of the time, people are having some kind of work-related musculoskeletal disorder, and over 10 to 20% of the time, some of these need surgery as an intervention. Looking specifically at the field of neurosurgery, there are multiple studies out on this, and in your guys' field in particular. You can see heat maps that are, in this particular study, a heat map was made of different types of work-related musculoskeletal disorders in these 3 specific neurosurgical procedures. But you can see that neck and shoulder pain are not insignificant when doing these types of. I see Bill over there, he's stretching his neck, it's making him sore. These types of injuries are not insignificant. And again, over 70% of neurosurgeons complain of soreness when they operate. 99, not surprisingly, because you guys are neurosurgeons, 99% of you just continue to work through it. But about 10% need time off work ultimately as a result of these injuries. About 15% have considered another job because of this. And again, about 10%, when you look at this study on over 400 neurosurgeons, about 10% have needed surgery, and you can see the different types of surgeries needed, most of which is cervical spinal surgery as a result. So why does this matter? Because about 12% of all physicians that have a work-related musculoskeletal disorder need time off of work, modify their practice to accommodate their disability, or engage in early retirement as a result of that disability. About 11%,
Jeff,
sir.
Quick question for you. As I'm thinking about this, how do you separate what may be related to the work now that they're doing, and I don't know if you can or not, versus their background? Like in your case, you played a lot of sports, you know, how is that going to affect, you know, 10, 20 years down the line, you know what I mean, type of situation. So is there a way to tease that out in these studies to better understand how the work that you do today has an influence on the potential health of your body in the future?
When you look at some of the questionnaires and things that go out to the various surgeons that are being inquired, some of them do sort of specify whether or not there's a temporal association, you know, whether or not you're saying, okay, well, do you notice on cases where you wear loops that you have neck pain when you're done, that sort of thing. So other than temporally associating it with the surgery that they're doing, I'm not too sure. But it is something that, you know, is actually made better. We'll talk about this in a little bit. It's something that's actually made better by people who have physical activity outside of work. So like the running that you do is helpful for your ergonomics long term. But
Gotcha.
as far as any tease out whether or not someone's history, if they have a history of a car accident or neck pain, or, you know, played football for a long time or something like that, whether or not that's contributing to the overall situation.
Got it.
When you, again, when we look at Epstein, who did a large meta-analysis on disability as it applies to surgery, about 85% of people were concerned about an attenuated career. I think the thing that's most surprising is just the fact that 90% of surgeons want some kind of ergonomics training, and about less than 20% wind up getting it. So cervical spinal pathology is present. About physicians are about 40% higher rate of cervical spinal herniation than non-physicians, and likewise, about 28% of plastic surgeons wind up having to leave their practice as a result of cervical spinal injury. 20% about a single episode, 8% with having multiple episodes of cervical spinal discomfort, and 7% result in changing their practice. So what are the things that are associated with this? Well, in general, longer operating hours, lack of physical activity outside of work. So again, if you go to the gym or run or do yoga or those types of things, those actually show they dramatically decrease the incidence of work-related musculoskeletal disorders. Women have a higher prevalence than men. When you're not the chief operator, that makes a difference. And I think we certainly a lot of faces in this room, they're all nodding. I think we've all been there, you know, when you're 6'5" and your attending is 5'8", it causes some problems with your ergonomics, your ability to be comfortable. Age and height, the older you are and the taller you are, the more they are associated with discomfort while operating. I have a picture of one of our chief residents who was 6'8", and he was when he was a third-year resident, he was frequently operating with one of our female chiefs who was 5'2", and so he was. I have a picture I'll show you guys later of him craned over the bed. It's not, but height is not an advantage when it comes to being a surgeon, it would seem. There is the impact of these things long term. I don't want to kind of beat a dead horse on it, but just chronic pain, disability, and I think ultimately it influences other main topics that are being talked about in the surgical and medical community right now, like burnout. You know, you go to work and you're sore every time you go to work and don't feel good when you're at work. It affects the way you treat patients, and it affects the way you treat yourself, and it affects the way you treat your family. And so I don't think that the need to address this can be undervalued. what specifically about our field do we do that contributes to work-related musculoskeletal disorders? Well, surgeon position. And it's funny because you think that if you are kind of working around the bed, like a lot of the times, like when I'm doing carotid surgery, I'm like looking up underneath the skin flap, and then I'm looking down into the neck, and I'm doing a lot of changing in my position. And people say, oh, don't you get sore doing that? And actually, I was like, you know, actually, I get really sore when I'm doing endoscopic cases. I don't really get sore when I'm doing these like dynamic cases. And sure enough, when you look at the literature, a static position, because you don't change the position of your head or neck, and because you have increased muscular tone the entire time in that singular position, is associated more with this surgeon discomfort than if you're being more dynamic. Loops, and we'll talk more about this in a second, but loops versus just regular glasses actually contribute because you are not really moving your head. Again, you're focused on a single magnified field, and not really moving your head very much because you don't want to rock the field while you're doing whatever you're doing. So loops versus direct line of sight, loops tend to have a little bit more in the way of discomfort. And then using a microscope and endoscopic monitors all contribute to discomfort. Also, the patients haven't made it any easier on us lately. Patients, it's hard to position patients in a nice neutral position. It takes longer for access, all these things when somebody has an increased BMI. And honestly, the culture, right? The surgical culture is such that the answer to you being uncomfortable in the operating room is oftentimes deal with it. And honestly, I think there's a lot to be said about being sort of strong emotionally as a surgeon, right? It allows you to deal with adversity and bad things when they happen a lot better. So I think that's just part of surgical training, is learning how to take a difficult situation. But you want to be doing this for a long time, right? So you got to figure out a way to take care of yourself and not just necessarily deal with it whenever you're feeling uncomfortable. The things that we do out of the operating room certainly contribute as well. Text neck is now a thing for formal physical therapy, musculoskeletal diagnosis. And this is a forward head position. Every single inch that you crane your neck further and further over your cell phone when you're out of the operating room, it applies additional 10 pounds of torque to your cervical spine. This has been studied in multiple venues, both in vivo and in vitro, like in the lab. But that increased weight leads to increased demand in the muscles and joints in your neck, and it also decreases your C-spine height over time. There are lots of basic science studies that have taken spines out of cadavers and taken a look at the muscular strain and torque to sort of back this up. And this obviously leads long-term to challenges. And honestly, we do a lot of sort of text neck head forward position is what that's called when we're wearing our loops and when we're looking into the microscope. So figuring out ways to mitigate that is of importance. The problem really is that we have static posture, or head forward posture, increases in muscle length, increases EMG tone in the neck, and that all leads to neck pain, cervical disc herniation, and cervical radiculopathy. So what can we do to try and mitigate some of these factors? Well, whoever's fitting you for your loops, you should try and have them address the line of sight of your loop so your head is in less than or equal to 25 degrees of flexion. You don't want to be looking down like this at 45 degrees or greater. A lot of loops are set that way. You want your declination angle to be less than 25 degrees and have a comfortable working distance. That will make you more comfortable as you operate. Another potential solution, honestly, what do we use loops for? Well, we use loops for field magnification, right? And three-dimensional visualization, right? So you can use an endoscope theoretically to magnify a field, but you don't always get a fisheye view. You don't necessarily get a three-dimensional view. So you use your loops for field magnification and for three-dimensional optics, basically. Exoscopes, which are 3D 4K cameras that can be positioned wherever you want in a room and have an associated 3D monitor that sits directly across from the surgeon, are now a thing, and they're being used more and more frequently. Before all of this went down, we were actually looking forward to trialing one here, and I think we're going to get that trial back on when some of these restrictions are lifted. Again, I don't have any interest with that company, but I do have an interest in using those cameras because they can offer a higher level of magnification and better field ergonomics for the surgeons involved. But here's an example of an exoscope where the exoscope sits above the patient and directly across, so you can see this person is looking at sort of an inappropriately placed monitor, but at a monitor, and this person is looking at a monitor right across from her, and you wear 3D glasses, and you're able to triangulate, and you're able to magnify, and honestly, you're able to magnify to a higher degree. You can get up, I think, to like 30, something crazy. It's like 32 degrees of magnification or something like that. So you can certainly, I've used Exoscope in Rochester for doing microsurgery. I liked it a lot better, honestly, than using my loops, which I traditionally use, and certainly like it a lot better than the microscope because the microscopes take so long to set up and drape and all these things. So this is just one drape, 2 monitors, and a pair of course, disposable glasses. When do we see it in ENT and neurosurgery? Again, with endoscopic and sinus surgery, about 80% of people that do this on a regular basis have some sort of work-related musculoskeletal disorder when doing skull-based surgery. And the solution for this is optimizing your monitor placement, right? So monitors should be located about 1 meter away from you. They should be at or slightly below your line of sight. They shouldn't be up above your head, and you can see this all the time. People would just kind of put the circulators would just put the monitor wherever it's convenient, and it should be at or below your line of sight, directly across from you, and you shouldn't be turning your head to look at it. That's how you optimize the use of a monitor. The 1 meter distance is optimal for relaxation of your orbital and ciliary musculature. And foot pedals, that's the other thing that we deal with, right? You kind of look for the foot pedal and sort of do the hokey pokey, looking for the foot pedal. Having somebody else run your foot pedal or putting it in a reliable, consistent location so you're not hovering over it can help you keep from standing on one leg while you're looking at a monitor while you're operating on somebody's brain. Robotic surgery. I don't know if we're using, you guys use a lot of robotics right now in neurosurgery or not so much? I think it's an expanding application. I think you're going to see it used for skull-based in the imminent future, as well as other applications. But robotic surgery is nice because it does, and I do a lot of robotic surgery for transoral robotics. It's nice because the surgeon's console affords you the opportunity to adjust basically 4 or 5 different head position, head tilt, where you put your arms, where you put your feet, how far out the foot pedal sticks. All of these things contribute to maximizing your ergonomics while you work on somebody. Studies on robotic surgery with ergonomics show that over the course of time, it decreases psychological stress, cognitive workload, and physical demand. But all of these things are related to how many cases you do. So the first time you sit down at the robot, it's going to be really uncomfortable for multiple reasons. But as you do more and more cases, a lot of these things get a lot better. And I know you guys use a lot of.
And I was going to say, Jeff, we do use, Selby has been pioneering a lot of the use of robotics on the spine, basically. And it is true, when I watch them work, you're more straight up, moving around. You're not in one single position. It's a little bit more dynamic, and you are not putting that stress on your neck. That's something, of course, we don't think about that in longevity of the surgeons, but it is true. And the skull base has been more challenging. I think the work that you're doing and now we're going to be doing together, hopefully we'll begin to pioneer that use of robotic more in the skull base, especially the temporal bone and down into the clivus. So hopefully in the future we'll be better at that.
Yeah, and as far as actual indications or applications for the exoscope too, a lot of lateral skull-based work's been done with the exoscope in replacement, in substitute for a microscope, and so I think that's going to be a good area for us to all explore. I know you guys use the microscope, right? So again, avoidance of a head-forward position, sort of neutral posture, all these things have been studied, and a lot of the literature for microscopy actually comes from the histopathologist, right? And pathologists, they spend all day behind the microscope. And again, not surprisingly, work-related musculoskeletal disorders is a thing in that field. but there are guidelines in place by the CDC that kind of help you work through some of that. Most of it's just avoiding a head forward position and keeping your arms in a nice neutral orientation. Time spent, I'm not going to spend too much time on this, but time spent out of the operating room, we're all spending a lot more time in front of computers right now, and so optimizing your computer workstation, even though it's not surgery and it seems like kind of the other thing that you do, you probably spend several hours a day now in front of your computer, so optimizing that will actually help you with your surgical career by way of saving your cervical spine and other areas of your body that you need to do surgery well long term. In general, we all like, when we're doing open surgery, to have our table at a certain height. Here's Brandon Peck, who is 6'8", and Deanna Minapache, two of our residents in Rochester. She's 5'2", and so when I took this picture, Brandon Peck, as a joke, took the stool from Deanna and put it under him, as you can see in that photo right there, so that he could be almost 7 feet tall while operating with Deanna, who is almost 2 feet shorter than him. But ideally, the surgical bed needs to be at a height. I always kind of put mine around the umbilicus, where you're with your elbows bent, you're kind of you have your instruments around elbow height. So you're kind of, you want to be sort of at the umbilicus, maybe a little bit higher if you need to increase your visualization or have a tough exposure, but most of the time it needs to be around that height. Lightweight items on the head. So if you have a headlight, making sure that it's lightweight. Infrequent use of loops, and I think the exoscope will help out a lot with this. Avoid, I will hurry up. And so the surgical floor mats can be used. You can actually find these really cheap on Amazon. I sure wish I would have invented this, since it's basically, as far as I can tell, a gel pad, and it's being sold for $1,100. But also for support, leaning slightly against the bed, and when you're seated, using armrests, and then periodic stretching and postural adjustments. And this is, I think, pretty interesting. I participated in one of these studies when I was at Mayo in Rochester, and I have to tell you that taking these sort of intraoperative micro breaks and targeted stretching, nothing has made me feel sillier than stopping a surgery to stretch out and taking a small break. And I wasn't like buying in, particularly when I was a resident, you know, and you're just like, you know, you want to be tough and strong, you keep on going. I'm not going to do any stupid micro breaks, you know. And this study, when it concluded, it was a pretty robust study. And these targeted stretching and micro breaks every 20 to 40 minutes did not increase operative time at all. The exercises performed were neck flexion extension, backward shoulder rolls. You know, all these things just seem very silly. But when you look at it, this is a smaller study, but there were 66 surgeons, and about 60% of them reported improved physical performance. 38% reported improved focus, and about 90% plan to continue to do them, and operative time wasn't increased. Again, there's all kinds of these trials in PT journals, physical therapy journals. And but looking at things, when you did when they had someone come in and do an ergonomics assessment of the operating room and try to optimize some of the things that we talked about, plus physical therapy or micro breaks during the operation. Again, after 6 months, people had improved quality of life, improved pain scores, decreased analgesic consumption, and about 76% continued to follow the program after the conclusion of the study when they were called on follow-up. And so, in summary, work-related musculoskeletal disorders is a thing, and I'm not, for coming here, I understand the importance of being tough and resilient as a surgeon. Bad things happen. It's important for you to be mentally tough. It's also important for you, though, to do things long term. I'm not here to tell you all to play victim, but I'm just telling you that as you do these things over the course of a lifetime, take the time for yourself to improve your ergonomics, do some stretching, do some physical activity outside of work. That way, when you all are awesome surgeons, and to all the awesome surgeons that are on the phone, including Dr. Q, take some time to optimize these things so you can treat people for as long as possible. Okay, and so there are general and specific guidelines. Take some micro breaks, and of course there are other educational opportunities. I think this Mayo is poised really well to do a lot of fantastic work in this field, and has done some fantastic work in this field. But we're poised to explore it further. If all else fails, you can always buy an exosuit. Apparently, this is a thing now that supports your elbows and your shoulders so that you don't have to support them yourself when you operate, I guess. But this actually is another thing that's being looked into. I don't know if I could go this far necessarily. I think I'm going to hold my own body up. If I did get an exosuit, I would probably do that. But thank you guys for your time and attention, and happy to take any questions.
Beautiful, beautiful, Jeff. Congratulations. What a great, amazing talk. As people are getting ready to take some questions, by the way, those signs that you hear that the conference was ended was just for the room, but we don't have to worry about that through Zoom, so we're good. We have a couple of minutes. I'm going to ask you, and then I'm going to ask Bill Clifton, who I think is still there, to make a few comments about the exercises that you like to do to stay physically fit for the type of surgery that you particularly do, which is physically exhausting. As you've been thinking about this, for you, what are the exercises that you particularly like to do to stay and have a long life as a surgeon?
Yeah, well, I used to do a lot more exercise than I currently do. I can tell you that. I personally think that running and swimming are really good. And as a matter of fact, there was a point in time when I graduated fellowship that I did a lot of triathlon, did an Ironman, that kind of thing. So I still enjoy doing those, although I do them nearly as much as I used to. Biking is kind of tricky, honestly. After long periods of biking, I noticed this when I was training for Ironman, that you wind up with your head in this, particularly if you're in an aerodynamic position, you wind up with your head hyperextended, while you have your arms down on the aero bars. And so that would actually cause quite a bit of discomfort for me long term. I don't ride like that anymore. I actually ride sitting in a more neutral position now on a different type of bike. I think more than anything else, though, actually, it's just the stretching and resistance training. I think has helped a lot, at least with me, as far as not feeling sore in the operating room. And then in the actual OR itself, I do take micro breaks. Like I'll go stand off to the side now and do, if I'm feeling like I'm in an uncomfortable position, or particularly during endoscopy or when I'm using my loops for micro and stuff, I'll go stand off to the side, do some shoulder rolls and neck flexion exercises like that study I showed you. And that helps me, I think, be able to focus a little bit more, and certainly it lets me be less sore at the end of the day. So at home, running and swimming, in the OR, actually optimizing the positioning of my equipment, using a mat, putting the monitors in the right spot, and taking micro breaks. Those are things that I do to optimize things.
And Bill, are you still there? You want to make a comment about this? And then I'm going to ask Ron Reimer also, because he's always kept himself very busy. Go ahead, Bill.
Yeah, no, I echo what Dr. Janus said. I mean, I used to be about 40 pounds heavier than I am now because I was a football player and did a lot of heavy lifting, but now I do a lot of stretching, and it's really about just doing it every day. So I used to do a lot of really intense workouts, and if I couldn't work out for 2 straight hours, I just wouldn't work out. But now I just realized that it's just a daily habit of just making yourself do it, just those 20, 30 minutes a day in high intensity, as much as you can, as fast as you can, a lot of body weight stuff. And also I think it's a lot about nutrition. So I think surgery is a performance sport. So, you know, eating right before you go to the operating room, and just making sure that you have, you know, it's more of a holistic view, kind of dialed in, just like a performance athlete. You know, they don't just go to the gym and then go home and pig out and, you know, drink a bunch of alcohol and then, you know, try to show up for work the next day. They kind of take it seriously about how much they hydrate their body and what kind of nutrients they're putting into it. So I think that has a lot to do with it too.
Yeah, really, that's a wise statement that surgeries are. I mean, more is expected of us, I think, than any performance athlete out there. And you're expected to do it from when you're in your 20s and 30s until when you're in your 60s or 70s sometimes. And so it is a marathon, right? I mean, it's a long time to be operating at a very high level physically.
Ron, you want to make a comment? I know that you have enjoyed the last few years. I watch you. I mean, you've always been extraordinarily fit, keeping yourself, inside of the operating room, outside of the operating room. What kind of stuff do you do to keep yourself both physically and mentally fit?
Well, thanks for allowing me to comment. I agree with everything that's been said by Dr. Janus, yourself, Dr. Clifton. A lot of emphasis on always trying to focus on work-life balance. So we do work very intensely in the operating room and in the office, but also trying to maximize our time away when we can get to the gym, be with our family, exercise. Nutrition, as Bill said, is extremely important. I do remember even, back working with Dr. Sutton, some of my mentors in Rochester, that we did want to always try to forge through the long cases, but even then it was evident that it was important to try to take these micro breaks that Dr. Janus just pointed out. Many, many years ago, starting to use those gel pads, trying to do shoulder rolls, adjusting your neck, and or all things that we intuitively know but need to focus on. So actually before Bill started his Jeopardy, I did my first set of push-ups this morning just to get ready for the lecture. And you can't overemphasize the importance of working on our physical well-being so we can work better to take care of our patients. So I think that lecture was really superb and eye-opening to see that all that's in the literature about this that many of us were not aware of, but it's so pertinent to our life. Thanks a lot for the great lecture.
I learned from Ron. He does in between cases, he goes up and down the stairs in the building, and then he goes to the top of the floor, and that's his push-ups and things like that. And it's amazing because he does two things. It relaxes him and also keeps him physically, fit and mentally concentrated. So, Dr. Hakim, are you still on the line with us? You want to make any comment? You're also extraordinarily fit over there in Colombia and keeping track. I don't know if you're still there or one of your disciples.
Yes, I'm here. I'm still here. And
thank you.
It's very interesting because I've always been in sports and I love sports. I think it's the best psychiatry you can ever do is do sports. And especially when you're in a I just heard a nice comment. I think surgery is like doing sports. Yeah, I mean, it's demanding. I always do sports. I mean, I've been doing sports at least an hour every day. After I finish my work, I go to the gym, and now we have a big group. We're cycling around. We do a lot of bicycle, but I think if you keep fit, you can also help a lot the patients. I always tell everybody, do the exercise you would like to do. You don't have to go to the gym. You don't have to run. Do whatever you want, but stay fit. And I think nutrition is also important. Eat well and be happy. That's what we do every day. Be happy.
Wonderful. Thank you, Dr.
One
Hakim.
other real quick comment. Team building with the exercise. I try not to do the stairs and push-ups myself. Steve Edwards and other APPs often join in and actually push me to go a little bit further and harder. And then many of us have adopted the ergonomic standing adjustable Veridesks in the office, which I encourage people to look into because we spend a lot of time in our office, and those variable height desks can be very beneficial along the lines with what Dr. Janus just lectured on.
I did notice that those desks that lift up allow you to have your head face to face instead of looking down sometimes at your computer. And they're definitely better for your neck and your back and your posture, your core muscles. So I try to do some team sports. I see Kai there on the line listening. I normally try to run the half marathon with him, except this year he didn't run it with me. I'm not quite sure why, but we normally try to do team sports. I don't think that he felt like he was ready for it this year. He was quite busy. He said he didn't train enough, but I tease him about that because the last year he ended up number 2 or number 3 in the overall in his age category, which is in like the high 20s or something like that. But it is good. So we have a group that we run together, especially in the half marathons, because most of us are only half crazy, not fully crazy. So great, wonderful.
We got a big case in about 15 minutes. I'm expecting stairs afterwards.
Wonderful. Well, listen, everybody, thank you. We had a lot of countries, a lot of participants, over 80 plus another 20 people in the room. I mean, it's amazing. And we're beginning to get a lot of more people. Hopefully our colleagues from around the world, Dr. Hakim, Jorge from Mexico, they're going to go ahead, and Jorge's next week, but Dr. Hakim will welcome you. In the near future, we'll coordinate with Tito to have you give another one of your talks, superb talks that we have heard you give, and a lot of the management of hydrocephalus and the innovation, the innovative work that you guys are doing. Same thing with our colleagues from Ecuador. I know that also from Bucaramanga, we have our dean also who join us. So thanks everybody. Have a wonderful day, and looking forward to many more events like this in the near future. All righty. Take care. Bye-bye.
Thank you very much.
Bye-bye.
Thanks,